And we are there. So I'm going to pick up where we left off, starting here for reinforcement. So hopefully everybody had, well, if you did not have the time, make the time to please listen to, I did 2 recordings, maybe a total of maybe a full class, like a 30-minute and a 20-minute recording. So, and I kind of left it here. It is a very complex system, and I wanted to save the most complicated part. But I was very favorably surprised, just to summarize, that there's a very good PowerPoint, if you want just for reference. So I wonder what the chapter, which I did not read in the text, is like, but this is good. I mean, it was, I actually, it's not often I would say that this was better than the one in the Marib textbook, but in a lot of ways, I mean, I like the illustrations here, and you probably had a fair amount of this, yes or no, in lab. Well, yeah, good. And without, I'm not going to, I want to focus on the physiology, but these are really good. Images wide, and it was a subtle error that was here that I pointed out. But that's the PowerPoint. But it really did a very nice job. Those are really great images because it's exactly what, I mean, it's a micrograph, what it looks like. Brilliant. And the artist renditions, yes. Oh, well, the people online, they're important. They can see it. Don't start. No one likes a wise guy. Don't start. Because you're friends with that lady in between the two of you. And already that's a strike against you. Because where is she? I want her schedule. You I like. Moving on. So as I said, I mean, it's like some of these were really good illustrations, really well done. And so I really like the whole way. And I think it summarized it really well to understand that we have filtration occurring here. And it just depends on where this unit called the nephron is located. If it is in the cortex, then the capillaries are going to be around the proximal and distal convoluted tubules. They're going to be then basically reabsorbing and secreting to finalize what goes out in the urine. If it's what we call, and there's maybe, 15% or so there's maybe, 15 or 20%, at the most 1 out of 5 or 1 out of 7 of these glomeruli have very, very long loops. They are located, we call them juxtamedullary because they're next to the medulla. In other words, they're right on top of the pyramids, and they have these very, very long loops of Henle. That's kind of the topic for today. A little bit about how the fluid gets retraced. So they're about concentrating the urine. And so it's really very nicely done in the way they've presented a lot of this, I felt. And so, again, this is the type of anatomy question you would have, basically a quote flow chart. And I probably have a flow chart like that, at least for one of the questions, but I think it's fairly straightforward. This is the difference between the cortical and juxtamedullary nephrons. And again, water balance and urine content, basically making the water situation right. Do I have to keep it? Do I have to concentrate? Do I have to dilute it? Depending, as opposed to here, this is more about reabsorbing the stuff we have to keep and secreting the stuff we don't. I talked at length about the juxtaglomerular apparatus, is basically a salt sensor and a pressure sensor, the way we auto control. You don't have to worry about your blood pressure unless your blood pressure is at a very irregular level or there's underlying disease. Blood pressure takes care of yourself. That's the good news. The bad news, so one of these systems. Bad news is nothing is telling you unless it's bad. When you start to get headaches, when all of a sudden your heart is starting to overwork, and it can be detected like on an electrocardiogram or on an examination, you don't know that your kidney's making a mess of things, okay, until literally it's too late. That's one of the things, that's why they call high blood pressure the silent killer. And one of the things it does, the kidneys have so many safeguards. Again, that's why I framed this with this early on. If you have 1/8 of your total kidney function available, everything's fine. And then when it falls below that level, next you have to be on dialysis. And the same is true for the problematic effects on your circulation, on having a stroke or a heart attack from this. It's really a fascinating thing about the body. This is an excellent illustration of it with the width of the incoming or afferent arteriole versus the narrow nature of the efferent arteriole. I do want to conclude kidney today. And these are just some of the things that can go wrong. And we've covered a fair amount of this already. And again, these are the big processes: filtration, reabsorption, and secretion. I also think that the way we concentrate urine is really another important process. But this is in classic anatomy and physiology. There are these three. And again, I keep this with one eye open to many of you taking like a licensure exam, and you have to know what the classic, what are they? They're going to ask you, what are the four things? Because there's only three, even though I think concentrating the urine is a fourth. And they're just, it's another useful chart telling you about how things are pulled in and out of here, etc. Whatever this just talks about some of the pressure, and I don't go into so much with you, and really how we basically, what's the determination when someone has poor kidney works or good kidney works, or are they tending toward kidney failure, or are they going to need to be on dialysis? We use this. The big thing is GFR, and we estimate that from blood tests. They do it all the time with mine, and thankfully they've always been in the good zone. Which brings us about almost where I have to be, and that's this. The one mechanism that's auto control is this one. This is, and we've covered several times, and this is just maybe the last time we covered it again. It's the renin angiotensin aldosterone mechanism. We see it with the adrenal gland, we see it with endocrine, and it is so vital, not only for auto control, but it's really important for sodium balance. We rely on sodium, particularly so in a lot of systems, tremendously. And the kidney is just another one of these where moving sodium in and out or through cells in the tubules is how we generate sort of power, current, actually more like current in a liquid or a flow sense, to bring things in and out, things we want to retain, things we want to get rid of. And so this is a famous mechanism. When the blood pressure is detected as low by those sensors, and that juxtaglomerular apparatus, they release renin. Renin is released as a hormone that's made by the kidney. It immediately acts on something that's already in one of those dissolved proteins in your bloodstream called angiotensin-O-gen. O-gen means inactive or precursor. The renin activates it. Angiotensin, tighten blood vessels. Angio for vessels, tensin for tightening them, increasing tension. Has a limited activity on the blood vessels. The big deal is when eventually that blood circulates to your lungs, and inside the lungs, where all the blood's going to go anyway to get reoxygenated, okay, in some way, shape, or form, there's a substance there that's in the lining cells called ACE, angiotensin converting enzyme. That angiotensin converting enzyme effectively activates it into the active form angiotensin 2. That really increases. So if you want to raise your blood pressure, you tighten the arteries. So angiotensin is particularly on the arteries. You're increasing that. Remember, that bottom number of the diastolic is all about tension. It makes you increases your thirst. Number 2. Number 3, it increases the release of antidiuretic hormone, which will retain water directly in the distal convoluted tubules and what are called the collecting ducts. And lastly, and as important as any of these, if not more so, is it induces the adrenal glands to release aldosterone. And again, aldosterone works in the same area, distal convoluted tubules and collecting ducts. Inserts little passageways that pull sodium, out of the filtrate, what will eventually be the urine, and water, of course, follows it. Science, very little lamb, sodium, water. It's easy for me to remember it. I'm trying to help you. I already know. And so I went over a little bit of this. The vast amount of resorption and the vast amount of secretion is already done in the proximal convoluted tubules. To be fair, and these are like standardized tests, where does tubular resorption occur? proximal convoluted tubules. Where does tubular secretion occur? Distal convoluted tubules. Okay, that's broad brush stuff, but that's the kind of questions you get asked on like licensure exams. Okay, they're not going to go into the fine points, even though the vast majority of both of these occurs in the proximal. But this is, you know, whoever they construct these tests so that you basically have a sort of a general knowledge to a satisfactory level. This is the big deal we talked about in endocrine with diabetes. Transport maximum. Each substance you can only pull back a maximum amount of glucose, certain amino acids, lactic acid, What happens is if you reach when there is more transport substance than the active transport mechanism can't handle, it expels into the urine. Classically glucose. That's how we know a diabetic is out of control. But moreover, the longer that those are all occupied, it changes those transporters, makes them less efficient. So in diabetics, when you're at the transport maximum, read that as uncontrolled diabetic. The longer you are there, it's going to make that control mechanism less efficient. So your transport maximum is going to go down, which means you're losing control over that diabetic. That's why it's so important to keep them. Aggressive sugar control is the underlying key for managing diabetes, forever and a day. For any of you who are going to be doing this, okay, and nurse practitioners, you do this a lot. It depends on what, particularly in rural areas. Okay? It's been at least my experience having practiced in one of those for 25 or 20 or so plus years. This is a real renal disease. When they say syndrome, we don't have an idea exactly what causes. For instance, diabetes is a syndrome because it's got a variety of signs and symptoms, but it presents differently in different people, like type 1 and type 2, and some that get end organ disease and some don't. So what it is, this it alters the glomeruli in such a way, and they're damaged. Could it be infection? Could it be a disease? Could it be trauma? Could it be some process we don't understand? Could it be heredity, etc.? Okay. And that increased permeability allows plasma proteins, and then because they're leaking out, okay, they're not there to hold fluid in your blood vessels, and you get widespread edema, swelling everywhere. Fluid accumulation, like we talked about, in body cavities and extremities, and then all of these are bad. Because with the fluid down, your pressure is down, okay, and even though these systems are activated, it's very difficult for them to efficiently change it. Okay. So it's something that you may encounter clinically. As I decided to read more about it, but I couldn't find something that was classically described. It's a frequent finding in diabetics. Does it have to do with these autoimmune deposits in the glomeruli? Probably. There are certain infections, but it doesn't follow a pattern. Certain viruses, but it doesn't follow a pattern. So by and large, the causes are unknown. That's why we call it a syndrome. But don't understand that the severity is extreme. Let's see. And these are the mechanisms. I don't go into it with our class, but basically they utilize sodium, the movement of sodium, either primarily, the primary active transport molecule is sodium. That's where the energy is expended, but it provides a gradient. In other words, it provides the push, or for that matter, the pull, to either bring stuff back in or get rid of stuff. That would be, I think, sufficient for our purposes that are there. 97 to 99% of sodium and water are reabsorbed before we get anywhere near the urine. And so these are all parts of it. And they give you some ideas of, for instance, how much water, 99% reabsorbed, how much sodium in grams. It's a lot of sodium. Okay, that's more than a pound. Easy, that's the better part of 2 pounds of sodium. 99.5% reabsorbed. So you can see the amount we excrete. So is that the major constituent of urine? For sure. They give you some diagrammatic stuff about this that you don't have to go crazy with. And secretion is just the reverse of reabsorption. We move it out. 80% of the plasma is not filtered by the glomeruli. Okay, so these substances are derived from that waste in large molecules. We transport them. So drugs, potassium, protons, hydrogen ions, part of acidity. So, and again, when we're moving more out of these, it's because we have an excessive amount of acidity. We want to bring it back to the normal range, or we have to hold on to it because we want to keep it at a different range. Okay. And again, the old story with potassium and sodium going in different directions. I mean, that's very broad brush stuff, but that's kind of how it works. And then there's a little bit about these, the aldosterone itself. Again, that's the one that triggers the sodium and then the water following it. When there's too much, what controls that is if you're retaining too much fluid, it causes stretching both in the atria and even in the ventricles. And that basically says, okay, we got to get rid of it. They're called sodium natriuretic. Natri is for sodium. Uretic means you get rid of it in the urine. So all of it is part of homeostasis. That's there. And yeah, as I said, it's relatively thorough. You can look through this. My questions, in answer to Allie's question, are going to be much more generic, if you will. I'm not, and I do this by intent. It's one of the hardest systems to understand, and we haven't even gotten to the hard part. Aren't you excited? Not excited. You're just going to have to know the basics of it. I mean, like two basic questions. You don't have to thank me. You never can tell, but you're going to need to do it. And this is this. How do we concentrate the urine? It's called, there are two systems that work in concert with one another. They are a wonderful design. It's all about the anatomical basis of the way that those pyramids are set up. The pyramids are set up in a unique way with those long loops of headlight. And because they make a hairpin turn. Thinking Westview around here. Anybody familiar with the Westview hairpin turns on 19? What fun are you? You know where I am. That's crazy. I mean, I can't imagine in the winter when those are icy. I am not driving there. Did you know in Westview they used to have an amusement park years ago? There's like some senior high rises. They used to have a Kmart over in that plaza. You know what I'm talking? That was an amusement park. My brother-in-law, who's my age, when he was like a 16-year-old and they were growing up in Bellevue, worked, like, put the kids on the rides, the little kids. He worked the amusement park. So he's my age. So you get the idea how long ago that was. It's, I was flipping burgers at a now defunct competitor for McDonald's. He was doing amusement park, but I was in New Jersey. He was here. Okay. So there's something called a countercurrent multiplier. That is that's what pulls out the water. And to balance it out, we have to pull out salt. And so now, and something called a countercurrent exchanger that makes sure that the salt and the water we pull out is pulled out in such a way that it allows us to continually do it. Interestingly enough, this is not formed at birth. This is starting to form at birth. That is why what's the average time for a child to be effectively potty trained? 2 to 4 years, let's say. It's during that 2 to 4 years that this mechanism, basically, you're going to see the numbers, how this interesting gradient is set up that makes your kidneys able to concentrate urine. So it's not something, because, you have a baby, you're changing diapers all the time. I have an authority on this, 3 years, 2 weeks apart, 3 kids. Mountains of diapers in our house. So what happens is you have an ascending and descending limb of these long nephron loops that are parallel to each other. And because of that hairpin turn, even though they're not touching each other, concentrations in fluid have an effect. Okay? It actually starts on the thick limb and ends up going to the thin limb. So the thick ascending limb, because it's thick, water can't get through. The thin descending limb, water can get through. So that's permeable to water. Okay. And so what I've got to show it to you better. So this mechanism is called the countercurrent multiplier, because each time the cycle is completed, it really changes the concentration. You're going to see what happens over time. And interestingly, where does that water go and where does the salt go that's being pulled out? That's because of these long blood vessels that are draped over it, called the vasa recta. They exchange, okay? And it's an exchanger because it doesn't necessarily expend energy. That a tremendous amount of energy to pull the water in and to pull some of these salts in. So here's kind of what it looks like. So initially, what happens is it starts here. It actually starts in the ascending limb, which is a little counterintuitive. You think the water's going down. So the thin, water can go out. In the thick, water can't, but salts can go out. And this happens, and over time, it starts with the salts, and then it begins to impact the other side. It's best I can explain it to you for now. And so it's a continual loop kind of phenomena. I got to show it to you. Let me see if they have the numbers. Rats. They didn't go into like crazy here, and I'm not going to ask you about it, but I do want you to be familiar with it. So let me do this. Pull up a slightly different PowerPoint just to show it to you. Should have done that previously, but I apologize. Same deal. Yeah, these illustrations are a little bit better. Again, I like the other picture very much. It comes after, and we'll get there. So what happens normally, the amount of stuff dissolved in our plasma, so the normal number of what we call for isotonic, which the extracellular fluid, the plasma is 300 milliosmoles, whatever that means. At the very tip of the pyramid, what has happened is your kidneys became truly functional for this purpose. At the very tip of that pyramid, it's about 1,200, 4 times as much. Okay, and that multiplier has made this gradient that allows salt to move out and water to move out. The exchanger preserves it. Okay, and then we vary it when we either have to make our urine more concentrated if we have to retain fluid, or less concentrated if we have to get rid of fluid. That's what it kind of looks like. So normally here, 300, all the way down to the tip here at 1,200. So if we flip through these really quick, and it's all based on this. Filtrate flowing in opposite directions, different permeabilities, and active transport, which is in the ascending limb. So even though they're not in contact, they can influence. Consistent difference of 200 milliosmoles always exists between the two limbs, okay, and it's multiplied on the long way. And they show you a lot of pictures, but this is a good way to look at it. If you did not know, when the urine eventually comes out, so this is the loop, this is the start of the distal convoluted tubule. The only thing that's going to happen there is if we have antidiuretic hormone, we'll pull back some water. If we have aldosterone active, it'll pull out some more salt and water. But you can see the difference. If it's 200 on this side, it's 400, 400, 600, 700, 900, all the way to the bottom of that long loop of Henle, all the way down to the deepest part of 1,200 milliosmoles. By the time this system does its magic, water has been pulled out of this side, salt out of this side. And it's now in this sort of interstitial area. That means between the tissues. It's in the material that's not involved in the loops. And it's in those blood vessels that are draped around it are going to pull the water and pull the salt so it can be maintained. And by the time that filtrate gets into that distal convoluted tubule, it's hypotonic. Your urine that you put out, for the most part, normally is hypotonic, meaning you're getting rid of water. You're getting rid of enough water to basically make whatever is dissolved and stay dissolved and maintain this idea of hypotonicity. So it's designed to get rid of fluid. I know it's problematic to explain it, but I felt strongly that I needed to show this to you. The exchanger uses the blood vessels that are draped over it. Same thing, hairpin turn, okay? And while the blood inside the vasorector remains isoosmotic, okay, it basically is absorbing equal proportions, appropriately equal proportions of water and salt to maintain that. So it maintains it, doesn't over-concentrate it or under-concentrate it without going, and I know I'm getting more technical than I want. So the exchanger removes the salt and removes the water. Easier. Thank you for making that clear. That's all it's trying to show you what it does. So again, the thick limb, it's salt being pulled out, and a certain amount of water may be inadvertently being pulled back in just because of its nature. And here, salt, these are the blood vessels that are there. Okay, these are the vasorecta. So you're trying to basically, as you can see, on one side, they're pulling out water. On the other side, they're bringing in water and pulling out salt. The bottom line is it maintains this gradient continuum. As long as that's working properly, we can concentrate our urine. It's all a function of how much urine is flowing through. So that's why first thing in the morning, we have at rest, we are able to highly concentrate our urine. And that's why the first morning urine is utilized so much for different things, whether it's early pregnancy test. Okay, you just have more of the stuff that's in there. It's pulled out water. So the urine there is going to be, if you're going to have to try to detect chemicals, that's the time to do it. Yes, most of the time when we do a urinalysis, it's random, but there's certain times where we want it early on. So all those things, overhydration. So the thing is, if aldosterone is present, additional ions can be removed, causing the water to dilute to 50 milliosmoles. See, in the absence of aldosterone, we would end up losing so much sodium. It would be extraordinarily problematic. Let me go back. That was just, I tried to give you a brief explanation without going crazy. And when I send you the reviews, I'll be very specific about what you need to know for this, because inevitably this is a source of confusion. Okay. So I know it's one of those areas that's inherent. There's certain areas that are hard on the final. There's certain areas of respiratory, there's certain areas of digestive, but urinary is always the one with the biggest problem. I think repro is fairly straightforward. We get into female repro and the menstrual cycle and the ovarian cycle, and that's what we're going to be doing a lot of next week. I'm trying to get this all in the interest of time. I am hopeful that on next Friday afternoon, and also that we don't have to go over this stuff again one last time. If we're going to do anything Monday afternoon before finals for the 3 people who are going to be there, okay, it'll probably be review stuff. Nobody left. Thanks. I don't like anybody. Oh, you're going to miss us, Dr. Stein. Not a bit. I'll miss Ava. She's pleasant. Plugged in, obviously. There's ear things in there. It's okay. I can take the hit. I don't judge. I'm like that. You thought I was an angry soul. I'm not. Okay. These are the nitrogenous weights that are so important. Interestingly, we even reabsorb some urea to create concentration gradients, even though we'll push it out later. So a lot of time, and the body does this in a lot of different areas. It's kind of how the proton motor force works. Uric acid, nucleic acid metabolism. Okay, again, there's a certain amount, about 10% enters the urine and is excreted. The trouble with uric acid when we have either, and typically it's a hereditary fault. This is where gout comes from. Typically, an enzyme is missing that facilitates our being able to get rid of it as efficiently. And interestingly, it's just like blood pressure. Medications are available that are easily used for people with high blood pressure that don't have really, if you on globally speaking, a ton of side effects. And the same thing for gout. Those are the kinds of things that are eminently treatable. Treatable is a great word, as you will find out. And here's the urine itself. Varies due to a lot of things, mostly water. Mostly, those are the nitrogenous wastes, urea, uric acid, and creatinine. Those are the things they look at in a urinalysis or in a blood test to estimate glomerular filtration. And then little amounts of other stuff that's there. Depends, half a liter to 2.5 liters. Okay, this is the normal output for most of us, and it's different things that do it. Are we working outside? Are we drinking a lot? I mean, everybody has different things that go on that are involved. So there's no way to say what's right and what's wrong. These numbers are not that terribly important for us. This is the whole idea of being able to clear something. It's a way that if you're going to do it scientific, like I'm talking about, basically to estimate it from blood tests, the way to do it scientifically is to do what's called a 24-hour urine. And what they do is they administer, this is a polysaccharide that we neither absorb nor break down. We don't absorb it and we don't secrete it per se. So effectively, we don't process this whatsoever. So this plant saccharide will cause us no problems. Whatever we take in, we get rid of. So we give a person a test load of this, and we collect their urine for 24 hours. Theoretically, it should all be going back out. If it does so, we can estimate accurately what their glomerular filtration rate is. What am I seeing that I'm not seeing? Oh. Don't ask me. So different types of clearances. So inulin is used, even creatinine can be used. Since these substances are both filtered by the glomerular and neither reabsorbed nor secreted, we can use these to calculate GFR. Okay, so when people have either chronic kidney disease or chronic glomerulonephritis, okay, there's a lot of problems that are associated with it. So these are, unfortunately, they're not necessarily curable. One of the things that has led to that, and it's more common in people of color than not, is called, it's renal glomerulodystrophy, I think, don't quote me, and it comes a lot from non-steroidal anti-inflammatories. The people who have had, every so often you will see a case in a very high quality athlete who happens to be a person of color having, and basically what these athletes are constantly having pain and inflammation but play, and they use a lot of non-steroidal anti-inflammatory drugs. Read that as a lot of ibuprofen or something similar. And in some folks, there have been, I can think of 2 world-class basketball players. Sean Elliott played for the Arizona team, and just his name was just sitting there. Played for Miami, played for Georgetown, was a center. Oh my God! And they both had to have kidneys replaced. So they both had to have kidney transplantation because it was so severe. So this is something. It created this chronic. Oh, it kills me when that happens. It's a big Georgetown fan. in college basketball.
It was Alonzo Mourning.
All right, it'll get to me. So end-stage renal disease from this, they had all of these things: high blood pressure, proteins in the urine, all of these different changes. And this is the sign when you have elevated BUN and elevated creatinine. That's what fortunately for me, transiently, when my kidneys shut down, put me in intensive care. Thankfully, I didn't have to do any kind of dialysis, or thankfully not have to have a transplant. So that's all of those. Alonzo Mourning, yes. I'm not. My mind is still functioning. I realize it's a while ago when this happened. So he was in the late '90s and early 2000s. This was this is a Hall of Fame basketball player. Sean Elliott was a Hall of Fame worthy basketball player from North Carolina. Rather, for University of Arizona, played a national championship team. Just giving some ideas. So this is a well-known problem that occurred. And so effectively, once the urine has effectively sort of dripped its way out of the tips of those renal papilla, the tips of the pyramids, it drains and makes its way through. And basically, there's no more processing that go on. So these don't really contribute other than problems. Does that make any sense? Other than to say that really only bad stuff happens from this point on. So the ureter is 25 centimeters, about a foot, transports this on its way down from the renal pelvis. Effectively, again, think of it as a funnel. The ureters are a tube of the funnel. I'm not really that interested in what's called. The big deal is now we have gone to transitional epithelium. What makes it transitional effectively is that if you would look at it when there is not fluid in the system, it's probably 7 to 12 layers. People erroneously think it's like stratified squamous. The cells don't flatten out. Stratified squamous, in non-keratinizing, the cells are dead, like your skin. In keratinizing, the cells are dead, like your skin. In non-keratinizing, we see nuclei, but they're flat. Transitional, they're sort of rounded. If you go back in AP1 and you look at the different linings where you did that chapter about that, you would see that. I'm sure you did it in the laboratory. And it's moved along unless there's an obstruction. Again, it's a tube, not unlike the esophagus, with little that expands. But when it's empty, there's little nooks and crannies, that little crystalline structures, and it can be calcium, it can be blood, it can be bacteria, things like that that get in there will cause, unfortunately, that it'll impact those peristaltic waves. And what happens when they're impacted is we call it, just like when a baby has colic. So we call it urethral colic. That's normally where kidney stones are found. That's what they look like. So those little areas, particularly when they're empty and a stone gets in there, all of a sudden cause spasm, reflex spasm. That's there. So uric acid, oxalate, very common. Our dog had that. A lot of dog foods are rich in oxalates in the foods that they have. So we had to have our previous dog, and this, he had to have a surgery to remove stones that were bladder stones that he had developed. Very, very common. Had a special diet. Okay. Pain, nausea, vomiting. Nowadays, we use lithotripsy more than surgery. It is extraordinarily painful. It was typically more common in men in their 30s and 40s. We are seeing it now in women younger. There tends to be, there's been an emphasis on taking calcium. You have to use the right kind of calcium. Okay. And again, calcium carbonate or oyster shell calcium. So if that's Tums, calcium carbonate. Okay, when you see that, if you're seeing Caltrate with vitamin D as a supplement, calcium carbonate, that does not have the tendency to form it. So calcium supplements, okay, you have to use the right kind of calcium. Excess vitamin D can be a contributing factor. It's a fine line. So it should be very watchful. One of my cousin, who's about a couple years younger than I am, She ended up with this when she was in her 20s, somewhere between her in that 25 to 35. She's close to my age now, but she was in her 30s and 40s. She ended up having to undergo the lithotripsy to get this up. We're seeing it more so in women than in men. The bladder itself is important because I had bladder cancer, so be on top of this. The flat area where the ureters enter and the urethra goes is called a trigone. Other than that, when the bladder's empty, it forms those ridges like the stomach called rugae. But that flat area is where infection tends to occur because there is not as much movement over that area. Okay, and again, we're looking at transitional epithelia. When the bladder's full, it looks like there's two layers. When the bladder's empty, 7 to 12. It's an optical illusion. They're 7 to 12, you just don't see them when it's filled with fluid. And we'll get into it when we do male and female anatomy. When we do for repro, I'd rather do it then, but you can see the location. The bladder is overlined by the uterus in the female and the rectum behind it. In the male, it's a little bit different in the sense that we don't have that large uterus playing a problem. So there's two different subsets of problems that I'll identify when we do the reproductive anatomy. So here you can see that trigone area. In the male, you can see the prostate. That's typically where the problem is. In the female, it's a little bit different because the uterus overwhelming it can create problems that are associated with it. That are there. Here's what that transitional, sort of the external cells have nice looking rounded tops. That's what it identifies them. And you can see the nuclei. So we know that's living. And again, we'll do the urethra more when we look at it in reproductive anatomy. And really, it's all about the anatomy. Why is such a problem? We see much more problem with urethritis and cystitis. In cystitis, we see more of it in females. In urethritis, we see more of it in male. There's a much longer urethra. It gets inflamed. And there's a different subset of infections that we talk about in micro. I'll talk in my micro class about that because we're getting to that universe sexually. I don't know if you're doing it. And if you're other taking micro with somebody else, they may or may not choose to get into it. I think it's really important. That are there. We'll get into all this when we talk about that in anatomy and physiology. I don't worry about urination or micturition. There's all sorts of different abnormalities that are there. The urinalysis, a great instant quick check on how everybody's doing. You don't have to go crazy. The urinalysis is one of the first things we test because it's easy. It's non-invasive. Non-invasive tests are very useful. They're inexpensive comparatively. You don't have to stick somebody. There's not a risk personally associated. And different things will cause different appearances in the urine per se. And then they have all this stuff, which you guys can read, which I don't like to read. Did I mention? By the way, finals week, at the end of finals week, you won't be here, but that Saturday is May 10th. That's right. Mother's Day is May 11th, but May 10th is my birthday. So if you're thinking presents, this is the opportunity to give me to them. I'm not trying to pander for presents. You won't help your grades. All you do, you can't influence my grade. But that's very bad to look at because my number will be 74. Imagine next year when I have to give this talk. That's why us old people are, that's why it amazes me why you guys are running to the bathroom and the old guy who should be is sitting here for 3 hours. What the fudge? Yeah. Kiss my goodbye. Have a wonderful weekend. That's right, I don't like you. We'll start repro in earnest. Male first, then female. Male's easy physiologically, female is complicated. What a day.